Right, good morning, everybody. I want to thank all the organizers for allowing us to put together this very comprehensive session on chronic total occlusions. My topic is on retrograde, but I wanted to start with these slides that talk a little bit about the hybrid algorithm and trying to understand that CTOs are not fixed. We don't have a fixed treatment. We have to be able to adapt to the different situations and change gears according to what is in front of us. And many times try to understand that we do not have to keep doing the same thing for hours and hours trying to get the result, because most of the time that won't work, and actually the answer is to try to change gears and use something else. Another important thing is that you got to look at the angiography over and over and over again. If you notice in some of the cases that were presented, the answer for the best treatment approach of this patient was another one that was done, and it was just by looking at the angiography that you can see that. So when retrograde might be your primary approach, in which scenarios? And I think when you have a very ambiguous cap or a stump-less occlusion, maybe retrograde is a preferred approach rather than antegrade. Ostial occlusions are also very challenged to be treated antegrade. When the occlusions are very long, those ones are also someone that you might consider retrograde. Severe proximal tortuosity or calcification, and as you have seen in some of the cases, some of these are very challenged to cross antegrade, so retrograde might be easier. Small or poorly visualized distal vessels, CTOs in vessels that are very difficult to engage, or anomalous coronary arteries that is very difficult to engage and got good support, and occlusion of an artery involving distal major bifurcation. So before we go into the more tricks and tricks, I want you to see these slides that it shows you that the patients that will have a retrograde approach are the ones that are having a more complex anatomy. So these ones are the more complex patients with a more complex anatomy. They are associated with longer procedures. If you see, the vast majority of these patients with worse anatomy are associated with much longer fluoro time. So you got to expect that if you are trying to do more complex procedures with a retrograde approach, you are going to have longer procedures, and you got to take in consideration also that part. And also, the complications of retrograde approach are significantly higher than the complications on non-retrograde approach, up to 4 times. So how do we plan to do this? And I think we got to, if you follow an algorithm, you will be successful in a significant proportion of the patients. The first one is, how are the collaterals? So you got to determine what is the type of collaterals that you're going to use, whether there are bypass collaterals, septal collaterals, or epicardial collaterals. And depending on those ones, you will have different type of challenges. You see the degree of tortuosity increases, and the epicardials, the wiring difficulties are much more significant in the epicardial collaterals. The ability to dilate the collateral is significantly easier, certainly when we use a bypass, and we should not dilate an epicardial collateral. So the risk of tamponade goes more significantly in the epicardial collaterals, and the surfing technique should be used only in the septal and not used in the epicardial collaterals. So the next step is to understand what is the angle that these collaterals are coming off and the angle of the collaterals getting into the receiving vessel. So that's very important, because this will tell you what type of wire you will need to use in order to go in the true distal recipient vessel. So another important issue is you need to evaluate the collaterals from at least 2 angles. We'll show you some examples, an example of that. So the other is you're supposed to be using the shorter collateral. However, you got to look at the whole diagram of the collateral, so you need to understand where that septal collateral will end up, because that will tell you which collateral you're supposed to use. Even the shorter collateral give you better support, not necessarily is the one that is going to give you to the final point. Collaterals with corkscrew morphology, collaterals with more than 90-degree angles at the recipient vessels may be challenged or impossible to wire. So you have this scenario, maybe retrograde is not the first alternative. So if you see in this, I don't know how projected this, but if you see here in one projection, you will see that the collaterals follows this direction. But if you see in the opposite projection, you will see that the collaterals is exactly in the opposite direction. So if you are at that level, it's very important to take two projections. You are going to be able to wire the distal vessel, the receiving vessel better. So here also, if you see the shorter collateral might be the one that you want to engage. But if you look at here in a higher magnification, this collateral doesn't go anywhere. Where if you go to the distal, the more distal collateral is the one that probably is going to take you to the distal vessel or to your receiving vessel better. So evaluation of the collateral is very important in order to be successful in this procedure. The other important issue is, as I mentioned before, is where this collateral is with respect to the receiving vessel. So if this collateral is too close to a bifurcation point or is too distal, it will give you some challenge to be able to go retrograde and wire. Whereas if there are no bifurcation points, then it is a good target, or if the bifurcation point is more than 5 millimeters, also as well as the distal cap. So if we are very close to the distal cap in the entry point into the receiving vessel, that is going to be a challenge for you to have support to be able to penetrate. So in those one, it's better to go into more distal collateral, where if the occlusion is, the distal cap is farther up, then the closer you get, the better, and the shorter the collateral, the better. So how do you cannulate the collateral? Usually I will use a normal wire, because sometimes you have to do manipulation. You don't want to damage your wire that you want to go through. So a normal wire, advance your microcatheter over this workhorse wire, and then after that, you will start to change over the wire that you will use for your collateral access. Sometimes you need to pre-dilate the ostium of the collaterals, and that it is more common when there is a stent across, that sometimes that happens. So if you have a stent, you might need to dilate the ostium of the collateral to be able to manipulate and advance your catheters. So after that, you exchange for your wire, and I think there is not a magic wire selection here. I think it's the one that you use more often. The one that you used to is better. So you can use a Fielder XT, XTR, which is, I know that is very popular in Asia, but I think the Scion is the wire that I use the most. But again, you can use either of these three types of selections can be a good alternative. Wire surfings and tip injection are appropriate technique, and you're supposed to use tip injection when there is a septal. Remember, no wire surfing in the epicardials. In the epicardial collaterals, you have to do wire manipulation. If tipping injection, when you do tipping injection, it's better to pull back the tip of the catheter a little bit, just to prevent to inject in the small branch or small collaterals that you might dissect that collateral or create some problems. Also, remember, it was emphasized by the other presenters that you have to do a very small bend, only 1 millimeter, and with the 30 to 40 degree angle on the tip. After that, penetration, and here you got to remember the distal cap is usually softer than the proximal cap, and therefore you can use softer wires initially. And if the case is that the softer wire will not work, then you're supposed to escalate to more stiffer wires. Retrograde knuckle dissection is also an alternative. So when we are in the distal cap and we try to cross it, so what do? Sometimes the wire will go forward and you advance your catheter, and sometimes your retrograde wire will go forward and will follow your retrograde wire. So the anterograde wire follows the anterograde wire, and there is nothing else to do. Sometimes doesn't happen that, and you keep wiring, and you need to change to an alternative approach. Don't keep doing the same thing over and over again. So this is the most common dissection system in which we use a balloon to dissect the artery. And currently we use the reverse card technique. In the past we used card technique, but we are not using it any longer. The reverse card is much, much easier because you can control your antegrade wire retrograde wire in the small cap, and then your antegrade wire forward. And so the other thing that is important is try to use smaller balloons at the beginning, because in that way you prevent a very significant subintimal space that might be more difficult to re-enter in your retrograde wire. So use a small balloon with the intention only to collapse the retrograde wire space, and then the retrograde wire who have the tendency to go into the true lumen proximally. So this is a simple case in which everything went well. So we have the LAD towards the right coronary artery. So you see that we always prepare the antegrade and always try antegrade first. This is in the subintimal space. Somebody may say, here we can switch over antegrade dissection technique. We decided that we wanted to continue and do, because of the very good collateral, we thought that it was a better alternative to do a retrograde, but remember that antegrade dissection, it is also an alternative. I know that in Asia it's not as popular, but it is a good alternative. So we have a very good septal collateral here, and appears to be very straightforward, and sure enough, it was straightforward. We go forward, and then we try to meet both wires with a kissing wire, and we advance the balloon antegrade. So we remove the retrograde microcatheter, we advance the balloon, and we do the typical reverse card in which we inflate and we get the wire into the antegrade, and then from here you make a decision. So if this, can I go antegrade on the antegrade wire through this, so we advance the microcatheter backwards, and here we can try the antegrade wire. If the antegrade wire goes, that's fine. We don't need to do any more sophisticated alternatives. We did the dissection, we re-enter, we advance the microcatheter retrograde, and then the antegrade wire can go forward, and that's fine. Otherwise, if the retrograde wire doesn't go, the antegrade wire doesn't go forward, then we will have to externalize the retrograde wire in the way that our previous colleagues show us. So you will snare the wire, reverse the procedure, use a different wire to reverse it, and then you finish your procedure. In this case, after we went backwards, the retrograde wire, the anterior wires went forward through the little channels that we create with the microcatheter, and we put a stent and a balloon stent, we size it with IBUS, and we finish the procedure. Sometimes it's not that easy. This is a 53-year-old gentleman with significant medical history of prior congestive heart failure, and he was admitted with monomorphic ventricular tachycardia, the rate of 200, so it was spontaneous terminated. The echo ejection fraction was 10 to 20%. They did an angiogram, and they noticed that there was a CTO of the right, CTO of the LAD, and the only patent artery was the circumflex. The patient developed monomorphic ventricular tachycardia again. The surgeons were not inclined to surgical revascularization. They thought it was a very high-risk patient, and was transferred to our institution. So when he came to our institution, we can see that the CTO of the right is very challenged. It's a long CTO. That is, the cap is not in the occlusion portion is completely ambiguous. We have no idea where this is. And then we see the LAD feeling retrograde, and patient was on a balloon pump, and you see again circumflex, but we notice here on the LAD that there was a little nipple here that we can go antegrade, so we attack this antegrade like the others have shown, and I will skip this portion. So, but eventually we were able to open the LAD, very, very nice antegrade with a normal antegrade wire escalation technique. So I brought the patient back to the right coronary artery a couple of days later, just exactly 3 days, and if you see here, there is a lot of contrast already retaining here. So what happened is when we injected here, we noticed that, that unfortunately it was a complete spiral dissection of the right coronary artery. So I've attempted anyway to go antegrade on retrograde, but it was very challenged to get the wire back into the true lumen in any direction. So we try retrograde, we try antegrade, and you will see how the wire will go, and our wire, retrograde wire and antegrade wires, I was not able to get the retrograde backwards, neither the antegrade forwards into the true lumen. The wire is going to be in the false lumen as we did this. So here we have the antegrade wires trying to go forward, retrograde wires trying to go backwards with any technique, because the subintimal space was so large and all a spiral dissection, I was not able to really get it back into the true lumen. Here is the antegrade wire into the subintimal space. So what I did was I staged for another CTO procedure. Now we have around 6 weeks, and you see that the dissection of the right coronary artery has healed completely, and we are back into the same in the same process that we were before. So sometimes waiting for healing for several weeks is better. So we try again to go retrograde, and you will see that we look at the collaterals here, very significant number of collaterals, and progressively we are going to move forward into our collateral surfing, and we have the antegrade wire here, antegrade preparation and retrograde, and the wire will go retrograde. However, we reach a point in which it was a challenge. You see the wires are meeting together here, but no matter what I did, I was not able to get the wire in the right place. Eventually, I was able to get the wire backwards and meet the two wires together. And I want to emphasize here the importance of dual injection. You see that the wires are very separated there, and here we move backward, and they are much closer. It's very important to use dual injection. So here we do the reverse card, we do the balloon, and eventually the wires will go in. So after several balloon indentation, not able to place the retrograde wire in the true proximal right coronary artery, eventually I was able to advance the guide liner distally. So what I did is I dissected the whole right coronary artery, and this is what is called guide liner assistance, a retrograde access. So the wire now goes backward into the guide liner, and at that point, after several balloon dilatation, I was not able to place, alternative to balloon reverse card, guide liner assistant reverse card, which what I did. Now we're supposed to what? Snare the wire, so use a retrograde wire exchange length RD3 for externalization. However, due to the collateral tortuosity, the wire will not advance into the guiding catheter, and even after dilating the collaterals, I was not able to advance the wire into the aorta in order to snare it. So I advanced the microcatheter even further after balloon dilatation of the septal, and I placed a guide liner into the LAD. And then what I did was I did the antegrade wire, and I went from the antegrade into the microcatheter that was inside of the guide liner, and then I forward the wire all the way in the antegrade direction. So this is very feasible to do. It is not a challenge because the guide liner, the catheter is inside the guide liner. It's kind of fixed, so it's not that difficult to cannulate that. And then after that, we go antegrade all the way here, remove the catheter, and balloon the whole thing. And this is the final injection after we open. So there are different things that you need to be aware on retrograde dissection. There are different techniques, different wires, different catheters, different support devices that you need to be familiar in order to get this retrograde procedure done and successful. So if you follow the algorithm, I think you will be successful in most of these procedures. I want to thank you, and I want to invite you, all of you, to come to San Diego in April next year for our SCAI meeting. Thank you.